This season of This Headache Journey is sponsored by gammaCore non-invasive vagus nerve stimulator, the drug-free solution for migraine and cluster headache. gammaCore is the first and only FDA-cleared non-invasive device to treat and prevent multiple types of headache pain via the vagus nerve. It's small, handheld, and portable for quick and easy treatments whenever and wherever needed. gammaCore is safe, effective, and easy to use. Learn more at gammacore.com. That's GAMMA core.com. Hi, I'm Adam Flaherty, and this is episode 3 of This Headache Journey, a podcast where I recount the many chronic headache interventions and modalities that I've tried over the past 15 years or so that you can be more informed and empowered in your headache journey. I've created this podcast because I've had daily headaches for as long as I can remember. And after I got married in my late 20s and became eligible for my wife's insurance plan through her company, I decided it was time to start exploring what could be causing my headaches and what options were available to me to reduce their frequency and severity. And a resource like this podcast is one that I wish existed at that time. Instead, like I'm sure you've been, I was bounced around between providers and specialists and just went on their recommendations for what drug to try next or which practice to visit next. And needless to say, that process takes a lot of time and a lot of money. So this podcast gives you new tools to add to your tool belt, ideas to bring up with your doctor, and maybe some options they hadn't even considered before that can be very successful for chronic headache or migraine patients like us. That's a great reason to subscribe to this podcast. Not because I think you'll be waiting on bated breath for each new episode, but because then you'll be able to easily revisit when you're ready to explore a new modality or intervention. So whether you're listening on Apple Podcasts, Spotify, Amazon Music, Overcast, Pocket Casts, Hark Audio, or wherever else, please subscribe or follow the show. And if you have a moment to leave a review, that'll help others discover it too. And if you find this episode valuable, please take a moment to text or email it to someone else you care about who suffers from chronic headaches or migraine. Okay, with that out of the way, I'll preface this episode about a procedure called Sphenocath with a reminder that I'm not a doctor, and nothing contained in this episode constitutes medical advice in any way. I think it was my neurologist at the time who suggested something called Sphenocath to me. I remember hearing the phrase and asking, what the heck does that mean? And as he explained it, I had kind of a difficult time understanding how flushing out and numbing a collection of nerves in my face could impact the pain I experienced throughout my entire head and neck. But, and I'm guessing you feel the same way, if it's the magical unicorn that enables me to live pain-free, of course it's worth a shot. I ended up having the Sphenocath done twice. And I didn't experience a noticeable reduction in my headaches after either appointment. But I do know that this is something that has helped many people. In the interview, which you'll hear in just a moment, you'll learn more about the science behind the Sphenocath, and you can decide for yourself if it's something that you'd like to look into. But first, let me paint you a picture of my experience. My procedure took place in a hospital. I was brought into the operating room, which was very sterile as you'd expect. The doctor ran me through what was going to take place as I laid back. He proceeded to swab the inside of my nostrils with a numbing ointment, and I fully expected it to be uncomfortable when they inserted thin tubes deep into my nostrils, and I was right, it wasn't pleasant. My eyes got very watery, and I put all of my focus on breathing steadily just to keep myself regulated. He proceeded to squirt the numbing agent. And I don't remember a specific sound or feeling when that was happening, but I do remember that my throat became numb, presumably from what they had put in my nostrils dripping down into my throat. They did this procedure with inserting the tube into the nostril on both sides, and the entire procedure only took a few minutes, probably 5 to 6 minutes all in. It definitely wasn't my favorite thing in the world, but it was also definitely tolerable, especially if it was going to work. After the procedure, the doctor asked if the headache that I arrived with had reduced, which it hadn't, and I was up on my feet and out of the hospital pretty quickly, and knowing that I'd be back for a second round of it within a few weeks. The second experience was nearly identical to the first. The same doctor and team, the same routine, the same outcome. Was it disappointing that I didn't experience the immediate results that some people do? Sure, but I certainly don't regret trying it because I do know, again, that Sphenocath has a relatively high success rate for people suffering from chronic headaches. I wasn't able to make contact with the doctor who performed my Sphenocath a number of years back, but I contacted a provider who I found online who has shared some pretty compelling thought leadership content about this procedure and found that his clinic performs Sphenocath frequently. His name is Dr. Demetrio Aguila, and he was very willing to join me for a chat about exactly what Sphenocath is and why it has such a high success rate for reducing headaches.
My name is Demetrio Aguila. I am a peripheral nerve surgeon in the Omaha, Nebraska area. My practice is Total Pain Solutions by Healing Hands of Nebraska.
When talking about a Sphenocath procedure, we're talking about a grouping of nerves called the sphenopalatine ganglion. And I wonder if you could start by helping the listener understand what those cells do in the body and what relationship they have to the sensation of pain.
Sure. So the sphenopalatine ganglion, I tell my patients all the time, it's a little bundle of nerves way back in the back of the nose. Strictly speaking, it's not actually in the nose. It's next to the back of the nose. A lot of people don't realize that your nose actually goes all the way back as far as between your ears. They think it's just this thing that sticks off the front of your face, but it's much more involved than that. And so it's kind of like a crossroads or a superhighway where you have a bunch of different types of neurons that pass through. It's an area that was discovered, probably, I don't know, maybe 100 years ago, maybe a little bit more than that, and found to be involved in a number of different functions of the head and neck and face. Now, as it pertains to pain, again, it was discovered largely by accident that if you numb up this bundle of nerves in the back of the nose, in addition to affecting whether or not somebody has a runny nose, it can affect headaches. It's not entirely clear why that is, but in some circles it's thought that it's because it affects some of the pathways, some of which involve, again, the autonomic nervous system, and some of those pass through different pain centers in the brain. And when you numb that up, you kind of hit a reset button on that pain pathway. And if there's a feedback loop which is causing pain when there really isn't some other underlying problem, then you reset that feedback loop, hopefully for the better, so that patient will either have permanent relief or at least some longer-term temporary relief.
And so before we get into actually talking about what the procedure is like, when I think of numbing or affecting the feedback loop as you described it, could that have other effects that are detrimental when you're trying to actually do something that is dulling or removing this pain?
That's a great question. So again, as we talked about, there's a number of different types of nerve fibers that pass through there. One of the things that's often treated using techniques similar to the Sphenocath is patients who have a really bad runny nose, right? And so in some patients, this will cause their nose to dry up some so that they don't have this dripping from their nose all the time. But in some patients, they might actually be overly sensitive to that, and you have a more profound effect than you expected. And then those patients can end up with a period of time where they feel like their nose is too dry. I prefer to just tell patients, well, your nose might be really dry. On the other hand, other patients will have a paradoxical effect. They might say, Doc, I was really stuffy for a few days or a few weeks afterwards. And so that's one of the potential downsides. One of the ways in which we can tell whether or not it's having the desired effect is by checking the temperature of the skin on the face before, during, and after the procedure. And then there's a small percentage of patients who will undergo treatment for headaches, and paradoxically, their headache will actually get worse, typically temporarily. It's not common, but it does happen. It's one of the things that we commonly warn patients about beforehand, that there is a small chance, maybe somewhere between 5 and 10%, that at least temporarily your headache will get worse.
I've had this procedure a number of years ago, maybe 7 or 8 years ago, and I had it twice. And that was the number of times that I don't know if it was my neurologist or my primary care recommended that I try it, to basically say, like, if you've tried it twice and you're not getting the desired results, you may not, want to continue with it. Where do you stand on that? If somebody goes through this procedure and they aren't getting the results that you're hoping for, how many times would you recommend that they try it?
So there's a lot of debate in the headache literature, and also in the headache community about Sphenocath. Obviously, there are a lot of proponents like myself, and then there are those who say, well, I'm not sure it's such a great idea or that it's actually helpful. I think a lot of that has to do with the different protocols that are used. There's not one really well-established protocol that I've seen that is universal in its approach, but there is some data to suggest that doing multiple treatments in short succession seems to be more effective than just doing one treatment and then waiting to see what happens for an unspecified period of time. In my experience, I would say of the patients that I see, and the literature bears this out too, that about 80% of patients who come in for various types of headaches, and the ones that have been looked at most closely are migraine headaches and cluster headaches. That's a really tough one to treat, and so this is an area that's been looked at. About 80% of those patients, or 4 out of every 5 of those patients, will get significant relief.
Wow.
Now, what I have seen is that of those 80% that get significant relief, about 80% of them will notice an improvement after the first treatment. But what I recommend to my patients in advance is that, regardless of whether you notice the improvement after the first, second, or third treatment, we should still do all 3 in close succession, because in my experience, even if somebody gets significant relief after the first treatment, the second and third ones seem to make a difference, both in terms of how effective it is and how long-lasting, how durable the effect is. And so routinely, when we've done this for patients in the past, they're excited about the results they get from their first round, and they're even more excited that the second and third round will have an even greater impact.
The flip side of that question is, if somebody is experiencing the desired results from that, they come back, they do the second, the third, maybe on an average, how long do the results last before you see somebody again and they come back to you and say, hey, can we do this procedure again? Because It's working for me.
So in my experience, patients fall into 3 categories. When we think about that 80% of patients who get, pretty significant improvement, they fall into 1 of 3 categories. I would say the majority of those patients will find that somewhere around 3 months or so, they feel like they want to repeat it. And so they end up putting themselves on a schedule of, roughly every 3 months they'll undergo the procedure, which, for patients who are familiar with Botox for migraines, they're used to that 3-month cycle, right? And so I think that that's not as big a transition for a lot of patients. There's another group of patients who I've found will have, they'll get maybe 1 to 3 months, and it'll vary based on a lot of different factors, based on, stressors and other factors. And so in those patients, again, I just tell them, let's see how it goes. You let me know when you're ready. And then the third group of patients, and these are the ones that I find actually the most exciting, and the patients are also the most excited about it. They seem to have what I would refer to as a cumulative improvement or a ramping up of their effects. So those patients will come back typically after a month. They'll say, well, doc, I got about a month of relief. Okay, let's do it again. So we do it a second time, and then instead of 1 month of relief, maybe they'll get 3 months of relief. Mm-hmm. And then they'll come back at the end of those 3 months, and they'll say, okay, let's do it again. And then the interval keeps increasing. And in those patients, we found that typically they plateau somewhere between 6 and 12 months, so they may get as much as a year of relief before they come back again. Again, I find that they're the most exciting for me because, you see that the previous treatments kind of build on each other. Now, it is possible that there are other factors, other lifestyle changes that they've made as a result of the relief that they got, which then is also contributing to an improvement in their headaches. But I don't know that anybody's looked at that very closely. It's not something that I've really pinned down myself, but I have seen that pattern, and it's one that the patients typically find very encouraging.
Have you found that the efficacy goes down after performing a certain number of procedures?
I have not. As a matter of fact, even in the patients who are on on that 3-month cycle, which is probably the majority of patients that I treat, what they tell me anyway is that, when we treat them the first time, they'll get profound relief. They may come in with pain that they describe as a 6 or 7 or 8 out of 10. When they come back the second time, they say, doc, the headache's coming back. But it's like a 3 out of 10 now. And each time they come back, it's less than it was when we did it the first time around. That's the effect I see, is that in the patients who do have relief, generally speaking, the effect doesn't taper off. It's the headaches that taper off.
I would imagine what you're describing is so encouraging for folks listening. Can you walk us through step by step what a patient can expect once they're reclining in your chair?
Sure thing. So, when I do the Sphenocath, I do it a little bit differently than probably a lot of the other listeners have heard of. Sphenocath was originally designed to be done under fluoroscopy. In other words, you have these big X-ray machines that are used in order to identify where the device is. The device is, it's this tube that through which you deliver the local anesthetic, and it shows up on an X-ray machine. So you do a series of X-rays while you're doing the procedure to make sure you're actually putting it where it's supposed to go. But I started my career as an ear, nose, and throat surgeon. And so a big part of our training is in sinus surgery. And these days, I would say, almost every sinus surgeon I know does it using an endoscope, or a telescope that goes inside the nose. That way, we get a really great view. Well, as a surgeon, I figured, if I can look at the area I want to be at rather than just guessing, I'd much rather have a view of the area that I want to numb up. And so that's how I do it. I take the skills that I learned as an ENT surgeon, combine that with the skills that I learned as a peripheral nerve surgeon, dealing primarily with pain, and that synergy is how we're able to do this. So what do we do? First thing we'll do is we'll have the patient sit up, and then we'll spray their nose with a medicine called tetracaine. Okay, this is a local anesthetic, but it's a numbing agent, not that different than what you might get at the dentist. But we just spray it inside the nose. And the reason for that is that if I'm going to stick a telescope up your nose, you want to be comfortable while I'm doing that, right?
Sure.
So the nice thing about tetracaine is that it has great, amazing mucosal absorption. In other words, the inside of the nose absorbs it really, really fast, and it starts to work really quickly and really well. So the key to this procedure is making sure it's safe. And one of the ways in which you make sure it's safe is you make sure the patient's comfortable, right? So you spray the inside of the nose, and then I have the patient lay back. Actually, the procedure chair that we use can tilt back. So we make the patient as comfortable as possible. Now, before I spray their nose, I put some temperature sensors on their cheek so that we can monitor their progress. And we mark down the skin temperature before we spray the nose, and then we mark down the skin temperature after we spray the nose, and then we check the skin temperature periodically during the procedure. And it usually doesn't take more than about 60 to 90 seconds for the inside of the patient's nose to get numb enough for us to get started. And what I'll do is I'll take the telescope, I'll put it inside the nose, I'll find that little pocket where the sphenopalatine ganglion is, and then I'll insert the Sphenocath device. And so under direct vision, looking at it through the endoscope with we have a camera attached to that, and I got a big screen. And if the patient or family members want to watch, we have it also on a separate screen that they can look at. And then I could see exactly where I'm putting local anesthetic, and then I just gently put a little bit of local anesthetic on there. And then we wait a few minutes. I do the same thing on the opposite side. What I'm looking for is a change in skin temperature. We want at least a half a degree Fahrenheit of increase in skin temperature on one side, compared to before we did the procedure. If we can get up to 2 degrees, then that's much more convincing. And again, this has to do with the fact that, unrelated to the pain, there are autonomic nerve fibers that go through that area. And if you numb those up, then you have a pretty good sense that you've also numbed up the fibers that you actually want to numb up in the pain pathway. But the other way in which we can tell is that patients will typically tell us at least 2/3 of the time that they feel better after we're done than they did, before they sat down. Overall, about 80% of patients by the time we're done with the third round of treatment, if you want to think of it that way. That whole process that I just described will take, depending on the patient, anywhere from 5 minutes to maybe 35 minutes. There's no rush. In my office, we typically set aside an hour for this because patients usually have a lot of questions, especially their first time. And again, it's really important that the patient's comfortable, because it can be a little bit anxiety inducing to have somebody come at you with this telescope and you're like, wait, that's going where? So we want them to be comfortable. We have a lot of patients ask, doc, is there something you can give me to relax me a little bit, beforehand? And I'm certainly not opposed to giving somebody a little bit of Valium beforehand, but I'll tell you that I'd say less than 5% of my patients actually end up needing that. They're so miserable. They're like, doc, I mean, if all I need to do is hold still for, 30 seconds at a time, I think I can do that.
From what you're describing, this has what to me feels like a very high success rate. And so I'm sure listeners are going to be interested in looking into this and maybe bringing it to their headache specialist or their neurologist to have a conversation about it. What does it suggest if someone who experiences chronic headaches does not get pain relief from the Sphenocath procedure? What would your next steps be with a patient like that?
That's a great question. So, those patients fall into a few different categories. In my experience, people who do the Sphenocath procedure are well-trained and they've got good intentions. Having said that, and I'm happy to acknowledge that, I might fall into this category from time to time also, it may be a technique problem, okay? Maybe due to a function of the patient's anatomy combined with the skill of the person doing the procedure, maybe the local anesthetic didn't go where it needed to go. And so it may not be that the Sphenocath isn't a good option for that patient. It just may be that somebody else needs to do it, okay? Another possibility is that maybe it's not the right procedure for that person regardless, again, maybe as a function of their anatomy, right? And then, of course, it's widely acknowledged that even under the best of circumstances, 20% of patients who undergo the Sphenocath procedure will not get the relief they're looking for, in which case, then we have to step back and take a look and say, okay, well, what other options do we have available for this? And it's possible that in those patients, they need more than one approach in combination in order to get the best results.
You mentioned migraine early on. You mentioned cluster headaches specifically. Are there any types or classifications of headaches that don't seem to be served as well by the Sphenocath?
I've not run across any, and when I look in the medical literature, one of the things that is so remarkable is that when the Sphenocath was first introduced, and this is still the case, you'll see this in the literature. One of the things that is highly, highly emphasized is that you need to make sure that before you do the Sphenocath procedure that you've ruled out anything that is potentially life-threatening, like meningitis, for instance, or a cerebrospinal fluid leak. And for people that don't know what that is, that's when you have fluid from around the brain leaking out into places where it's not supposed to go. Now, why is it that you need to make sure that somebody doesn't have that? Well, because apparently in the early studies looking at this, the Sphenocath was so effective that it would actually hide some of these life-threatening conditions.
Oh, wow.
Even though the headache is the hallmark of those types of conditions. And so that should tell you a lot about how effective it is in the right patient. And so, the literature seems to suggest that it's worth trying on just about any kind of headache, again, once you're sure that you're not missing something, really important.
Well, this has been super educational, super insightful. Listeners, you can find out more about Dr. Demetrio Aguila's practice at totalpainsolutions.net. He's also got a big library of YouTube videos on his YouTube channel, and I'll be sure to link to all of those in the episode notes. Dr. Aguila, thank you so much for sharing your time and your wisdom with us today.
Oh, you're very welcome. Thank you for inviting me. It was a pleasure and a privilege.
Chatting with Dr. Aguila made me wonder, is Sphenocath something that I should explore again, potentially with a different provider? Of course, with anything we try for our headaches, the time commitment and the cost are factors. With Sphenocath, the time commitment is low, and if you're going to get results, you'll notice them fast. As for the cost, with the proper referral, insurance may cover some or all of your procedure. For me, 2 procedures were recommended in order to determine whether the Sphenocath was working for me. For Dr. Aguila's practice, he recommends 3 sessions, and if you're paying out of pocket, the cost at his clinic is $4,500 for those 3 sessions. So, how does this all sit with you? Does this episode make you want to explore Sphenocath with your doctor? please let me know by leaving a review of this headache journey on Apple Podcasts or wherever you listen. And again, please take a minute to text or email this episode to someone else who would benefit from this knowledge. In the next episode, we'll dive into how the connection between the eyes and the brain can trigger severe chronic headaches, and how visual training has helped so many people. I want to thank the team at GammaCore, the non-invasive vagus nerve stimulator, for sponsoring Season 1 of the podcast. And I want to thank you for joining me on this headache journey.